Good afternoon, everyone. Welcome to our Aware webinar today on psychosexual health and depression. My name is Dr. Susan Brannick, and I am joined today by Dr. Natasha Langan, who I will introduce more formally in just a moment. So we just give a few moments or so to allow people to join. So just taking a moment to get settled, and we'll get going shortly. Maybe as we're waiting, just taking a few moments to do some breathing to arrive in, if that's helpful, as we allow people to join the webinar today. So just maybe not changing the breathing, but maybe settling into the breath, maybe feet on the floor, connecting in with the breath wherever it feels most alive for you. It's just allowing a gentle arrival into the session. And on the next in-breath, taking a deeper, more intentional breath in through the nose and out through the mouth, letting go of the practice there. And welcoming to all of those who are joining. So again, you're very welcome today. My name is Dr. Susan Brannick. I am clinical director here at Aware and a clinical psychologist, and joined by Dr. Natasha Langan, who, as I said, I'll introduce in just a moment. But maybe just briefly to introduce the webinars for those of you who aren't familiar. So we meet on the second Wednesday of every month, discussing a range of mental health topics. You can find more information on our website, aware.ie, that also has information on our counselling service, education and support services. And I guess just a note on today as well, we'll get into it in a moment with Natasha, but just thinking about if you're left with any questions, maybe, please do ask us anything as we go, as we're discussing it. But if you are left with any questions or anything that comes up from the webinar this afternoon, maybe speaking to your mental health professional or GP. So, but we'll do our best to answer as many of the questions as you have. So, Natasha, you're very, very welcome this afternoon. Thank you so much for joining us. So by way of a brief introduction, Natasha is an NHS trained clinical psychologist, accredited psychosexual therapist, and European Society of Sexual Medicine certified sexologist, and a mindfulness teacher, and also holding a health psychology background. So thank you very much, as I said, Natasha, for joining us. Do you want to maybe introduce yourself a little bit and maybe explain to our viewers how you got into this area, and maybe the work that you do?
Yeah, so I trained in the NHS like yourself, Susan, and but before that I did my undergraduate degree in UCC, and that was in applied psychology. And in our final year of the degree, we had a module on human sexuality by so it was that module that really kind of opened my eyes to human sexuality. And I remember at the time wondering what my pathway might be after my degree, and thinking I'd love to do research around healthy sexual functioning and pleasure. But that was back in 2006. There was no funding at that time. And so I decided to then train as a clinical psychologist and specialise. So I worked for a few years, got on to training in Southampton Uni, and did my 3-year doctorate there from 2009 to 12. And I did my specialist placement in sexual health, so that was more around HIV. But during that placement, I was introduced to a psychosexual placement. So I did a day a week there, and that's where I was really introduced to, working with sexual problems in individuals and couples. And over the years, I went on to specialise and did a further diploma and got my accreditation with COSRA, which is the regulating body for sex and relationship therapists in Ireland and the UK. So fully accredited with them. And just a real passion for this area. And I suppose psychosex, and we're going to talk about that, what
Yeah.
that means and how it intersects with, health psychology, mental health, physical health. So
Yeah.
so it's really great to be here,
Yeah.
giving
Great.
space to this topic that's not often discussed, I think, in mental health
Yeah.
settings. So.
Yeah, no, thank you so much for that introduction. And also you're right, aren't you? It's not hugely discussed, even thinking back to my own training about how much time might have been allocated in those 3 years to
Yeah,
this, not so much. And I guess maybe naming that as well in terms of this is a these conversations maybe sometimes can be difficult to have in terms of
definitely.
mental health. Maybe for people who are using services, people who are offering services, sometimes there can be challenges around kind of talking openly about needs, about anxieties, about a whole range of things.
Definitely. And I definitely see that sometimes professionals are quite anxious to bring up the topic, and then even, clients themselves. So there can be barriers for both the professional and the client. And we know that from research that, even in medicine or clinical psychology, there's not a lot of time given to, sexual medicine kind of teachings or trainings.
Yeah, yeah, absolutely. So I guess maybe kind of thinking around intentions for today is, and as I mentioned at the beginning, if people are watching and have questions, please do ask them. We'll do our best to get to them. And maybe just starting a bit of a conversation because we could talk about this for quite a while, couldn't we? So maybe it's
Definitely.
just planting some seeds
Yeah.
that people might then kind of look up further information on or kind of get some kind of tips and techniques maybe for how they might have a conversation that's going to be of use to them with
Mm-hmm.
whoever that might be,
Yeah,
maybe. Yeah,
definitely. Absolutely.
great. So do you want to define for us maybe even what we mean by psychosexual or psychosex and how that what kind of what the parameters of that are maybe?
Yeah. So with psychosex therapy, I'll just explain that we're clinicians that are specially trained in a talk therapy that really focuses on working with individuals, couples with sexual problems. And like hopefully we're working with people to overcome difficulties and challenges in their sex or intimate lives and improve quality of life. But in terms of psychosex and sexual health, it's quite a broad term.
Mm,
And within sexual health, we hear a lot around maybe STI prevention, and but actually it's more than that. It includes we're thinking about sexual rights, sexual justice,
mm,
pleasure, sex education. So it's quite a broad term, and when we're thinking about psychosexual functioning, which will fall under our sexual health and
mm,
well-being, we're thinking about you know, well, we're also thinking about what is like what's a healthy sex life for a person? Like what would that look like? How would someone be
mm,
flourishing in their intimate life? So,
mm,
and there's an emphasis on problems. So the problems we might see typically in a psychosex clinic might be for men, erectile difficulties, premature ejaculation, delayed ejaculation, anxiety around sex or intimacy, performance anxiety. There could be
yeah.
sometimes compulsive sexual behavior, and for women, we might see pain around sex, vaginismus, pain conditions in the vulva, which could be vulvodynia,
Mm,
vaginismus, where there's maybe a fear of penetration, and then involuntary tightening or spasming of the pelvic floor. Muscles, we can have people that struggle to orgasm with anorgasmia. Again, general anxieties around sex. For both
mm,
males and females, we might see people that have had a sexual trauma and it's impacting on their current sex life. We might have people coming to terms with their sexuality, making
mm,
sense of what that means for them, or maybe overcoming trauma and maybe not coming out earlier on in life. So there's a lot going
mm,
on. And we also work with people with physical health problems. So, we know that men with cardiovascular disease, higher rates of erectile difficulties, in diabetes as well.
mhm,
During menopause, because of the hormonal changes, women for the first time might be experiencing pain during sex, mood
mm,
difficulties as well. So there's a real intersection with physical health and and also
Mm.
the impact of these conditions on our mood, our self-esteem, our relationships, our quality of life. So,
Yeah.
and that's why I'll just finish this. But we use that biopsychosocial model.
Yeah.
So thinking about, the influence of the biology, physical symptoms, and also how that interacts with our psychology, our thoughts, feelings, beliefs,
Mm.
and how that is all influenced by culture and context. And so we really have that kind of holistic way of thinking about psychosex problems we
Mm.
might see in clinic as well. So
Yeah. I mean, that sounds really helpful. I guess just even thinking about what you're saying about the men with cardiovascular challenges and having, so I guess, and that's maybe a good example, is it, of
yeah,
what might be biological, psychological, and social as well. Yeah, because
yeah.
I guess there's quite a complexity to some of this.
There is, yeah, and that's why there is the specialist training that we do, and a lot of
Yeah, yeah.
clinicians maybe will have a background in psychotherapy, clinical psychology, even medicine, and then they do
Okay.
their training to specialize as a
Mm.
psychosex or sex therapist.
Okay. Yeah. And I guess maybe I maybe normalizing to hear that maybe people might be struggling, and that these problems aren't uncommon.
Very
Um,
common.
yeah, really common. Yeah, so
Yeah.
that's good to hear, maybe. Yeah. And I think that the bit you mentioned there is interesting as well about also how you might flourish in that part of your life and how that might intersect with the different parts. I think that's probably really important as well.
Yeah.
Um, with a physical health condition, without one, and also kind of with depression and without depression, it's probably quite important, isn't it?
Yeah,
Yeah.
definitely. And it's why with sex education, hopefully it's sex positive. There's an
Yeah.
emphasis on pleasure, on boundaries, consent. So it's yeah, I think we still have a way to go in terms of
Mm.
sex education, and hopefully with sometimes for some people they don't need sex therapy. It might be just sex positive sex education might be enough
Okay.
for someone to know,
Yeah.
like you said, that these problems are really common. Maybe they're
Mm.
common with a condition like depression or
Mm.
cardiovascular disease, just to normalize and validate people's experiences. So sometimes that
Yeah.
might be enough for some people, or
Yeah.
some people might
Yeah.
need a bit more of a focused therapeutic intervention.
Sure. Yeah, yeah, that makes a lot of sense.
Mhm.
And I guess in terms of depression, obviously we know there can be a whole spectrum of that, can't we? So kind of mild difficulties to something more severe where someone might be seeing their life is really impacted. And I
Yeah,
guess just even thinking about depression, obviously it's an experience of a low mood, isn't it? A
mhm.
pervasive low mood, but also maybe feelings of emptiness, maybe a lot of self-critical thoughts, maybe a lot of body image
Yeah,
challenges,
yeah,
changes in eating, changes in sleeping, certainly changes in energy and pleasure more generally. So I guess in many ways it might make sense actually that kind of sexual health is going to be directly impacted, and maybe that might work both ways potentially.
yeah, yeah. People talk about that bi-directional
Mm.
nature, that sexual problems can have an impact on mood, anxiety, low mood, confidence about yourself, about your sexual self-esteem, confidence about yourself in relationships, and then depression, like you said, all of the symptoms could have an impact on energy levels, energy to have sex.
Mm.
You're having sleep difficulties and insomnia with depression, that could have an impact on energy, whether you're sleeping with your partner or not because of difficulties. Definitely some of the negative thoughts we have with depression and how they might impact on how we view ourselves sexually, or attractiveness, or whether we're lovable or someone would want to be with us. And then when we're thinking about the impact on the sexual response cycle, so you have
Mm.
desire, arousal, orgasm. And so for some people, there might be, an impact on their libido or desire to have sex. For some
Mm.
people, it might be there's an impact on arousal, so erectile difficulties, lubrication issues, or some people might struggle to orgasm, which might be different than when they're feeling better, or the quality of their orgasms change. And for a lot of people, if they've been offered medication for their mood, that will, we know that the SRIs will have an impact on the sexual response cycle for people. And also it's really important to say that for some people, we usually think of that when we're low in mood, we may not have an interest in sex, but for some people, there may be an interest. It might be that they notice that they're using sex as a way of regulating their emotions or to self-soothe. And that might be that there's an increase in porn use. For some people, there might be an increase in riskier sexual behavior. And or else they just want to feel better, feel more alive. So they may seek more closeness with their partner, so I think when we're thinking about depression, we're really thinking about what that means for the person and how that's impacting their intimate life, their experience of sexuality. And I suppose as a clinician working in the area, when I work with someone, I'm trying to see, does depression best explain their symptoms, or are the sexual difficulties living with untreated, undiagnosed vaginismus or erectile difficulties leading to mood difficulties? And then if we treat the sexual problem, then it might mean that their mood kind of improves, their confidence improves. So, that's why a thorough assessment is really important, I think.
Yeah. Thank you. I mean, there's so much in that, Natasha. It's hard to know where to start in a sense. Maybe let's start with that bi-directional piece. So how might someone, because that might be a question that someone has kind of who's watching, do you know whether this is whether mood is kind of changing, that's like one part of that cycle, or whether it might be going the other way, as you said, kind of if you treat for that, maybe if someone has erectile challenges, then that's treated, then their mood will improve. How might you as a clinician, how might the person kind of together go about teasing that apart or figuring it out?
Yeah, so I think, say with erectile difficulties, if someone were to come and see me, like when I worked in the NHS, I worked in a multidisciplinary team. So I would have worked with clinical physicians with it, and worked closely, say, with gynecologists, clinical nurse specialists, physiotherapists. But so we want to rule out an organic cause for, say, erectile difficulties, so checking that their physical health is okay, and that maybe there's not a physical reason for the erectile difficulties. And that can be really helpful to have a GP that you're working closely with to do bloods, and we can rule that out. But when we're doing an assessment, so if someone were to come and see me, I'm taking a physical health history, I'm taking a mental health history, I'm, thinking about current stresses in their lives, past experiences with mental health. And then I'll think with them, what's the problem? And I'll often say in your own words, like, what's led to the referral and how would you describe the problem, and when did it start, and what maintains it, what helps, what doesn't. And then I'll go through all the different points of the sexual response cycle. So asking them about libido, desire, foreplay, what they're comfortable with, around penetration, erections. They're very specific questions, just so I can get an idea, like, where might the problem be specifically. And we also do quite a thorough sexual history as well. So asking people about, even their experiences growing up in their families, their parents' relationships, their experience of going through puberty, their experience of sex education, their early experiences of relationships. So we take a lot of information there. So I think that helps me formulate around, having a working formulation about what might be going on for the person, and that might inform my treatment plan. So if I did think, actually, this is a mood difficulty and it's untreated, I'd be maybe saying, go back to your GP or psychiatrist and let's treat the mood and see, does the sexual problems can improve. And if I thought, actually, there's a big psychological or a psychosexual component to this. If we treat this, this is going to help with mood. So I suppose like it's just that kind of assessment, and then see how the treatment goes, and you can reformulate or revise.
I guess as you kind of gather that information and then kind of work through it. Yeah. And I guess then maybe just thinking about the cycle that you mentioned. So I guess thinking about desire, arousal, and what was the last piece you said?
Orgasm. And resolution is the last part, when everything returns to essence.
So, and I guess maybe then thinking about depression, even in terms of something like, I guess, libido or desire, how would you kind of explain how that biopsychosocial model kind of might work, if that makes sense?
Yeah. I'm just thinking about cases to explain it. So if we think about maybe a menopausal woman or perimenopause, and thinking about where, so if you think about physically what might be going on, so there could be hormonal changes, mood changes, there could be changes in the vagina, because a decrease in estrogen and how that impacts lubrication. So that's the biology, physical side. That's some of what might be going on. And then there's the psychology, maybe how they're feeling in themselves, how they're thinking, the kind of beliefs they have about them sexual selves during that time in their life. Like, is there mood difficulties, their confidence, also. And then there's the social side. I'll come back to the psychology as well, is at that time in maybe someone's life, their kids, for some women they might have young kids, for some women they might have adolescent kids, for some women they may not have any children or families, but there may be care and responsibilities with parents as well. So you thinking about their system, there might be a lot of stress in there, and also about what's happening in their relationship if they're with someone for a longer time. So there's lots of different factors going on there that might be impacting their experience of low desire. Like, if someone's experiencing pain, why would they be motivated to have sex? So it makes sense that they might also start to experience low desire. If you're not getting home with your partner and there's a lot of arguments and fighting, or you're carrying a lot of the burden at home, or care and responsibilities, you're probably too exhausted to be motivated to have sex. Or with all of the changes and what it means to be a menopausal woman, what that means for you, how that might be impacting on your sexual self and your sexual self-esteem. So there's a lot going on there that might be impacting someone's experience of low desire, and that's what we're thinking about. We're being very curious about what's going on for someone in their life, in their relationships.
Yeah, it makes a lot of sense, doesn't it? And I guess it gives a lot of sense then as to why you take a very full assessment with people. And I suppose even someone watching, maybe they don't have access to a therapist like yourself, but there can be that kind of curiosity maybe. I guess the thing that we haven't mentioned yet, we're 23 minutes in, so maybe it's surprising, but is maybe shame and self-criticism too in that. And I guess maybe it speaks to what you mentioned earlier about what does a healthy kind of sex life look for an individual. That's going to be different, isn't it? Or for a couple, or that's going to be, it's quite unique. And maybe shame can be part of I think shame can be part of depression anyway, can't it? And then also it can be very live in terms of sexual health.
Yes, sorry I didn't mention shame, but
no, not at all.
Every session, all of the work, that's what you're working with. And what we know is that shame breeds in silence and dark secrets. And so it's like I use a lot of compassion focused therapy in my work, and compassion practices and mindfulness practices. So it's central to the work. And how do we give people permission that they have permission to have a pleasurable sex or intimate life? And sometimes the sex education that we get or didn't get early on in life, we might have received messages that masturbation or pleasure is bad, or sex is bad, or shameful, or And we know that in highly conservative or religious cultures, there can be higher rates of sexual problems just because those messages, negative messages around sex.
Yeah.
And that can create a lot of shame in turn,
Yeah. So I guess there's lots of social aspects that are going to feed into what happens for people. Yeah.
Definitely. And thinking about our context as well, our Irish context of,
Yeah.
being really aware of just the influence of religion and some of the abuse that's happened in
Yeah.
Ireland, and so and how that impacted people's sexual selves, how they relate to others, and intergenerational trauma, maybe what in families where abuse happened, or so
Yes.
or shame is carried. So
Yeah, absolutely. And I guess maybe it feels, I don't know if you would agree with this, but it feels a bit more hopeful when you kind of hear how younger people might talk about sex and kind of
yeah,
sexual health, and it feels a little bit less shame heavy, but maybe
yeah,
that kind of moves in different ways, certainly from years ago in Ireland. Hopefully
yeah.
it's a bit more improved, but as you say, probably a bit more work to do.
Still more work to do, but I do. What's really hopeful, what I love is we in psychosex services in UK, but even in practice in Ireland, is that we see people that are maybe late teens to people in their
Mm.
60s and 70s, wanting to
Yeah.
explore their sexual lives or be empowered sexually. So that's really brilliant to see that people across the lifespan, open to doing work
Mm.
in this area.
That's great. And actually, I'm glad that you mentioned that because there's a question there that is asking how old is old when it comes to sexual health. I'm not sure I fully
Oh,
understand that, but
I think,
so,
yeah, it's interesting because I like I've worked with people in their 60s. I think someone that was 79. So I think there is no age limit, and I think
yeah.
the Kinsey Institute in the US, which kind of
Mm.
studies a lot on sex, sexuality, and sexual behavior, like a study just come out about masturbation in women in their 50s and how um, you know that people that continue to engage in self-pleasure, masturbation, the positive impact on mood. So I think it's giving ourselves permission that we're sexual beings. Society, media, what we see in Hollywood, we don't often see older people having sex,
Mm.
but people are like. I think we know that having a healthy sex life is the people that continue to have sex into older years. There's a
Yeah.
high correlation with health, quality of life, and mood. So I think it's an important public health message that we can continue
Mm.
to be sexually active into our older years,
Yeah.
and also to look after our sexual health, because I've worked with some people that think that maybe because there's no risk of pregnancy that they don't need
Mm.
to look after their sexual health, but really thinking about their sexual health. And because we see higher rates of chlamydia in some of the older people that may be
Okay.
divorced and kind of
Yeah.
now exploring relationships for the first time. So just to really be mindful of that is still important, to mind your sexual health as well.
Okay. So you mean like STI tests
Yeah.
and that kind of thing? Yeah. Yeah.
Yeah. Yeah.
Okay. Yeah. So I see what you mean. So yeah. So that's still relevant.
Still
Yeah. And I
relevant.
guess
Yeah.
sometimes people may feel it's not. Yeah.
Yeah, I know it is.
Yeah. And I guess then the just thinking about something else you mentioned there as well, I guess 'cause it is a complex area, isn't it? I suppose you say that even thinking about that, it's a nice example you gave about kind of how desire might be impacted by low mood, and low mood then might
Mhm.
impact on that too. And I wonder if it's just worth speaking about a little bit more of that cycle, kind of specifically how depression might impact then arousal and orgasm and
Yeah, yeah. So if you think about depression, there's quite often quite negative thoughts about self, about ourself in relationship. relationship to other people, and how that might impact our mood, feeling low, the physical sensations or symptoms of depression like fatigue, that feeling of heaviness, the ruminations, the preoccupations with negative thoughts. And if we're thinking about desire, that might mean that someone might have negative beliefs about themselves as sexual beings, and or as unattractive, or that maybe a belief that no one wants to be with them, or feeling quite isolated from their partner, a lot of self-loathing maybe around that. So that might mean that they isolate or withdraw from their partner. So that could impact on desire. For some people, it might be that they want to feel alive. They want to feel something. So it might drive sexual behavior, whether that is with their partner or, more casual sex or riskier sex. So that could be how it might impact desire. In terms of arousal, because of if someone's on an SSRI, it may impact on erections or erection quality or difficulties. And for some women might experience vaginal dryness, and also then, like I said about orgasm, there might be, because of a decrease in sensations, they might struggle to orgasm, or it might be delayed, it take longer or more stimulation, or it might be that the quality of the orgasms change, and it could be distressing for people, quite upsetting for people, so that might fit back into their experience of low mood. So there's many stages there, and it's quite complex. Like you also mentioned about shame, about body image as well. If you're not feeling great in yourself, in your body, you might avoid sex or intimacy with people as well. So
there's a lot of room for self-criticism in it, isn't there? Potentially, and maybe challenging in relationships too. But how that might impact the relationship. I'm just going to add in a question here, just because it's sort of slightly relevant, I guess, just thinking about the kind of cultural ideas about sex. And I suppose just that what you were mapping out there in terms of how kind of low mood might impact each part of that cycle. So I'm going to read this question out as it is, and maybe we can think about it together. So I'm wondering about working with people around sexuality and sexual functioning, where the communities they're part of have an expectation of sexual activity before emotional connection. And I guess so that's kind of where social expectations might overwhelm the personal need and can then lead into low mood. I think maybe it's a nice example actually of the people might be in very different contexts.
Definitely. And even when we think of context, we can think about society, culture, but also our peer relationships, our family origin. So the systems that we're immediately in, and if there's an expectation that casual sex is fun and that's what we do, and if you're someone that needs more connection but engage in casual sex, how that might impact you the next day, or yourself, how you feel about sex, how you feel about yourself. So, I've heard that from people saying that they've tried casual sex and it wasn't for them, that maybe on a night out with more alcohol involved, they thought it was a good idea, or they actually quite liked the attention, but the next day they're feeling really bad, and just recognizing that isn't good for them, but recognizing for someone else that might be great experience, that might, so it's definitely trying to think about, like Emily Nagotsky talks a lot about your brakes and accelerators, like what helps you accelerate, excite, what's a brake. And so always trying to meet someone where they're at and thinking about what are their brakes and accelerators. So and then thinking about the influence of, say, peer relationships and messages they receive around sex. So just to help them kind of think for themselves about what they need in their sexual life, intimate life.
Yeah, no, that's really helpful. I guess it requires, maybe as we were saying at the beginning, it's not something that's talked about a huge amount, certainly in mental health services, and maybe people have different experiences of talking about it with a partner, or maybe with a new partner, with a partner they've been with a long time. So there's something about that openness, isn't there, about how you might kind of have those conversations.
Yeah. And it's, I suppose it's not, like I would say it's not a one-off conversation.
Yeah.
It's a number of conversations, and what might work for you early on in a relationship might be different kind of later on in the relationship. But
Yeah.
having those conversations, having the courage to name some of what's going on, it does take courage, and some people will get it and some people may not. And but it's important that if you were ever shut down or felt judged or criticized for giving yourself permission to say, you have sexual needs or you want to ask questions, that it doesn't mean that you were wrong. And to, if that was with a health professional and you were dismissed, maybe seeking a second opinion.
Okay. Yeah.
If you notice an impact of your mood on medication on your mood or sexual functioning, that you have permission and to look after your sexual health and to ask for that symptom or complaint to be heard, I think.
What was that last bit, sorry?
The symptom or the problem to be heard and addressed by a professional.
Yeah.
And in relationships, long-term relationships, even though you're with someone a long time, it might be still hard to have these conversations. And that you've noticed changes in some sex life, that there could be discrepant desire where one partner wants sex more than the other, which there might be a mood reason for that. And how do you start a conversation with that? Because for some people, they want to avoid and not talk about difficulties. So how do you bring that up? Is challenging. I would say not inside the bedroom, maybe, not in the moment. If there's been a difficulty, maybe you come away and afterwards kind of check in with someone. And if a new relationship, like I've heard, it's what feels right for you, but you don't have to kind of share everything straight away with someone, because that might leave you quite vulnerable. But maybe thinking about, do you feel safe enough to kind of open up with this person?
Yeah, I think that's really important, isn't it? So there's a level of safety, as you say, maybe not immediately in the bedroom after something's happened or not happened, but it's maybe in a more neutral kind of setting, and you're kind of prepared maybe for what you want to say. I think that's really key too, isn't it? That you don't have to share everything at once. Certainly with a new partner or a partner you've had a long time, you don't have to do all of it. And as you say, it's not necessarily a one-off conversation. Maybe it can start the seeds of kind of talking about it a bit more. And I guess if someone wants to kind of say like, well, how would I go about it? What would you suggest with a partner, or maybe if they're noticing that the mood has affected their sexual health?
I think to just name it in a really compassionate way, what you've noticed. And there's also like the physical side of having a sexual problem. You want to really rule out that there's nothing what we call organic or physical happening. So it's a really bit about thinking about looking after your health. So I think naming it, and even if you're not having penetrative sex, if there's difficulties in that area because of erectile difficulties or pain during sex, how can you still be intimate? So maybe having a conversation, how can we connect as a couple? Because for some people, if there's a sexual difficulty, sometimes intimacy can stop altogether. So kissing, cuddling, hugs, because there's a fear that it would lead to X, Y, Z. So I think it is important to, if you're a partner in a relationship, to maybe name what you've noticed, and not in a blaming, judgmental way, but from a place of compassion and concern, and that you're working on it as a team, as a couple, that you're in it together, and hopefully you're going to find solutions together, and that if you're going through a depressive episode, that maybe for all couples at different points in the lifespan of a relationship, or as a single person, you might have your sex drive's really good, or you have more sex, and other times, maybe young kids, there's an illness, depression. There might be times where you're not having as much sex as you usually do. But how do you just know that that cycle will pass and come back around again, and that you can still connect together in other ways? Maybe that's just a couple on the bed or whatever way of connecting together.
Okay, so that kind of might bring that connection back in a sense, or maybe kind of thinking about it a little differently.
Yeah.
I'm just gonna take a look at a couple of the questions here. And so a few sort of coming in around. Well, I guess they're all very good, so and they're all very relevant. So maybe just kind of going back to, and this, maybe there isn't an answer to this necessarily, but maybe even just thinking about, someone's asked about the kind of relationship being able to climax through self-pleasure, but not with your partner while having depression. I would imagine that's quite common, is it?
I'm actually doing research at the minute on the impact of ADHD on sexual functioning, and we hear that a lot, that it's easier on their own because there's less distractions. They can just focus a bit more in the body. And so for a lot of people, self-pleasure or masturbation can be easier than with a partner. And sometimes there's less pressure, expectation on performance. So, and that can feel easier than if you fear losing your erection with a partner. Self-pleasure might feel like a safer practice as well.
Okay.
And sometimes self-pleasure is about regulation. It may not be about sex. There was a study come out of why people have sex, and 237 reasons. So sometimes to go to sleep, to feel better, to relieve stress. So makes
Who
sense.
do they ask? Just a general population?
Study back, I think from Texas, and just come up with loads of different reasons why people what motivates someone to be intimate. So
yeah, that's fascinating, isn't it? And also maybe really important, as you said, that masturbation might be part of a self-regulation strategy. And I guess, as you were saying earlier, I guess there's such a complex overlapping, I think, with so much of this, isn't there, in terms of what might kind of play out in terms of your sexual world and your internal world, and how that kind of clashes sometimes with your body reality, and that can be really challenging for people. So I'd imagine masturbation can be quite, as you said, kind of just a very different context that maybe offers something kind of different, certainly if you are experiencing a low mood. There's another question in here too, just maybe touching on what the example you gave earlier about maybe someone in the perimenopause, and just this person's kind of reflecting on what a change their sex drive took, and maybe not massively being prepared for that. And I guess the question is the conversation becoming more visible for women starting the perimenopause? I guess we'd hope so, wouldn't we? And that conversation might be part of the HRT conversation, that it wouldn't just be limited to these are the options.
And knowing that pelvic floor physio, really important. HRT, that there are options for women, and if you're experiencing pain, you might also experience low desire because of that, or just having that education will help us understand and giving permission, empowering us to seek help and support.
Yeah, that's great. And do you want to say a bit more about the pelvic floor exercises?
So pelvic floor physio, or women's health physio, like, I'm a big advocate, and when I work with anybody with pain in the pelvic region, I'll be recommending pelvic floor physio. Just so we normally assume that, for some women after childbirth and menopause, the pelvic floor does lose tone. So there may be incontinence issues. There might be more difficulties that women haven't seen before. But for some women, I might see they might also have like a tight pelvic floor, or hypertonic pelvic floor, have hypertonicity in their pelvic floor, and that can lead to pain during sex, or tension in the pelvic floor. So women's health physios or pelvic floor physios, they're specialists in working with that muscle group, which
Okay.
and so really important for women across the lifespan to visit, and particularly around menopause because of the hormonal changes and the impact on the muscles. So
Okay.
definitely
And
recommend.
okay, and maybe we might share some resources after the
Yeah.
webinar, kind of the stuff that goes out after if people are interested, and what exercise they might be able to do if they want that. Um, there's a question there about what the treatment is for erectile dysfunction
Yes,
broadly.
broad. Yeah. So
Big
I
vast.
think, yeah, so for medically, you might someone might be offered Viagra,
Yeah,
Cialis.
yeah,
Psychologically, we'll help them just if there's a big psychological component to the difficulty, and we've
yeah.
ruled out physical, then we'll be thinking about helping them understand that vicious cycle of the impact of anxiety on thoughts, beliefs, how that will impact arousal. So the fight and flight response kind of impact in arousal. So, our survival response is always going to trump everything else in the body, particularly arousal. So if you can
Mm-hmm.
understand that and then give someone skills to, help them regulate. So anxiety management skills, mindfulness skills,
Yeah,
sex therapy techniques called losing and gaining is one that we encourage people to practice. So this is homework practice,
yeah,
practicing masturbating while it's hard, and then the practice involves losing the erection and doing that
yeah.
cycle a few times, and it's about building confidence in erection so that if you do lose it, that there's the confidence it will come back.
Okay.
And also thinking about communication skills as well with a new partner, or with a partner, how you're going to
Yeah.
navigate that. And just to recognize their, like Bernie Sell, I can share resources, has an old
Yeah.
book now called The New Male Sexuality, but he talks about that fantasy model of sex.
Okay.
So, where we see sex is like Hollywood or porn,
Mm.
and it's not a realistic kind of
Yeah.
presentation of what real sex looks like. And so
Mm.
some people might, they might need to be educated on just,
Mm.
the sexual response cycle, their anatomy,
Mm.
normal, what average penis sizes are, so
Yeah.
there'll be a lot in the work as well. Just a
Yeah, I
lot
don't
of
know.
education and skills based work.
Yeah. But I guess, and yeah, it's really interesting, isn't it? And you're certainly saying it's much more than Viagra, I think, for that specific. And that's probably the answer for a lot of these challenges. It's going to be much more than just one thing, isn't it? Maybe that's back to the biopsychosocial model. And just maybe to tie into what you mentioned there, because there is a question specifically on that, which I think is an interesting one about how much does viewing porn affect male interest or performative performance negatively?
Mhm, mhm.
I guess, as you say, there's the kind of Hollywood version, and then there's pornography industry, which is also very different again, and where that lies in terms of people's actual realities.
Yeah, and I think I'll ask people in assessment, what's your relationship like with porn? Some people might get in touch because they want support around their porn use, and they feel
Mm.
that they have a problem with it and it's causing distress for them. Some people might have a healthy relationship with it, that it's part of their
Yeah.
sex life, and
Okay.
no problems with it. So it's really thinking about the person and what it looks like for them. If you're preferring to use porn over having sex with your partner, and that's creating relationship difficulties, well,
Mm.
that might be something you want to address. If it's not, then is it um, some people might find if they're being single for a while and they're masturbate alongside porn, and then they're with a partner, they might find that it's very different, or they don't have the same stimulation, whether
Okay.
that's visually with porn or sensory wise
Yeah.
with their own touch. So they might have
Yeah.
to do some work around, conditioning around their
Yeah.
how they
Okay.
masturbate and
Yeah.
have
Okay.
sex. Then so they might, yeah. So if they've got
Mm.
into a particular way of engaging in
Mm.
self pleasure, and then it might be harder to them when they're with someone else. So they might
Yeah.
maybe doing a bit of work around that, to
Yeah. Yeah.
presence in the body.
Yeah, it's an interesting area, isn't it? Because I guess
Mm,
you'd want to do the work, as you say, maybe some people might be getting in contact because this is causing an issue. Maybe
yeah,
other people, their partner is feeling it's an issue and the other person
yeah,
isn't. So I guess
exactly.
it's a bit complex, isn't it?
Yeah, it's one of
Um,
the questions I ask is, who's this a problem for?
okay, yeah, that's a good question. Yeah. There's and I know we're kind of don't want to bombard you with questions, Natasha, but and we're coming to the end soon enough. But I guess there's just really fascinating questions in here, you know. And my apologies if we don't get to yours. Um, we'll do our best with our resources, and as I said, maybe speaking to your a mental health professional if it's around medication and sexual health is probably a good place to start. Or kind of if there's anything else, maybe GP or maybe whoever might be relevant in that mix to speak to. Um, this question though is interesting, and I'd be interested to hear your view on it. And no need to apologize for the question, whoever's asked it. So thank you. Is there such thing as the G spot? Is it real or just a myth? There seems to be a lot of mixed information out there.
It's a good question, and so what I have heard, and I've been to some sexual medicine conferences, is that there is no such thing as a G spot. But what they think it is that the clitoris is when it's aroused and engorged, it's quite a big organ, and we only ever see the tip of it on the outside of the vulva. But it actually, oh, I don't have my, oh yeah, no, I have it here. I don't know if we've time for this quickly. Just so
I think we
this,
do.
yeah. Okay. So this is the clitoris. So not
Yeah.
many people might know this. It was only in 1998 that a female urologist in Australia using fMRI was able to see that this is what it looks like. So it goes down
Yeah.
each side of the lips of the vulva, but actually goes quite back. And
Yeah.
just like the male penis becomes engorged with blood, the clitoris does as well. But sometimes we're not that aware of it because, but if someone is able to touch a spot inside the vagina, they think it's actually the clitoris. And
Okay.
it's why it might lead to pleasure and orgasm as well. But it's really, they think it's the clitoris being engorged, and you can feel that through the vaginal walls. That's what they think.
Yeah. Okay. Well, that's fascinating. Yeah. Oh, I'm glad that person asked that question and we got
Mhm.
to see that
And
model.
Helen O'Connell is the urologist in Australia, and she's
Yeah.
done some podcasts, and
Okay.
she's brilliant to hear her story as well. I
Yeah.
think she's done a TED talk too. So
Okay. Brilliant.
incredible
Yeah.
woman.
Yeah, I guess it's interesting, isn't it? Maybe it makes me think of smear tests and the kind of history around them. And I suppose the history around women's health more generally, it's probably not surprising it took till
Yeah.
1998 for any kind of exploration medically of women's
Yeah.
bodies. So that's
She
maybe,
Yeah, she was enraged that the medical books had no information on
mm,
neurology textbooks, and there was a line like female. It was a failure of the male genitalia. Basically, that's how it was
okay.
said.
Yeah,
So her
yeah.
anger motivated her to do the research. So
Okay. Well, that's
it's
great.
yeah,
Yeah. And I guess it maybe points to how far we've come, maybe in a relatively short time. But as I guess we were saying, there's still challenges around this, and I think that biopsychosocial model is probably really helpful. As you said, that there's going to be so many cultural, social aspects before you even to get into someone's upbringing and personality style and their relationship to their body, or like it's quite vast, isn't it, in a sense? So I guess,
yeah, and I think
yeah,
that's why it's really important to work with someone that's trained and has had
yeah, okay,
specialist training, because there are people out there that might say, that they work in the area. But I think just making sure you're working with a clinician, especially trained,
yeah,
like looking up COSRAT, which is the College of Sexual and Relationship Therapists, has a directory of all the people that are accredited or registered. So in
yeah,
Ireland, we have 13 accredited psychosex therapists.
13.
13, but there are a number
Okay,
that are registered that they'll in the next few years they'll be working towards their full accreditation, but they'll be
yeah,
able to see people as well. So just to know
oh,
that
okay,
um, that's where you go if you want to find a
okay,
clinician that's
yeah.
trained and specialist in this area.
Yeah, I think that's really helpful because I guess if you want a conversation around this to be helpful and informed by a clinician, don't you? Like they're coming from a place of specific training. And for mental health professionals or health professionals more generally who might be watching this, where would you signpost them to kind of upskilling or building confidence, or like what small steps do you think could be helpful?
So I think there's some great sex researchers out there with podcasts that are amazing. Emily Nagotsky, Justin Miller. So I can share some of these.
Great. Yeah.
They're really good at just um, educating yourself, and
Okay.
they're informed by science and research.
Yeah.
I think COSRA is the accrediting body. They do online workshops and seminars that you can,
Okay.
on different topics, and they can be really good to sign up for. I think just looking out for any training in the area. I know the HSE, like there has
Mm.
been some training on working with diversity, and they do have a sexual health
Great.
promotion team, and they do some
Yeah.
upskilling for HSE staff. So just seeing if your organisation has anything. But I think COSRAT, and then podcast literature, and
Mm.
I can share some of them with you.
Yeah, that would be great. Yeah, thank you. Just I guess for anyone who's interested, and I thank you to everyone who's joined us today, whether you're a health professional or maybe someone living with depression or maybe just having an interest in this area. Hopefully we've kind of given you enough to think about, maybe, as you said, kind of maybe planting some seeds for further thinking. Um I wonder, Natasha, maybe what, like, as we kind of come to a bit of a close now, what do you think would be kind of for you the most kind of helpful or important thing for someone watching to take away? Maybe if any of this resonates with them, you know?
I think it's really important that you're not alone and you're not
Mm,
broken. I often say that
yeah.
you could be very alone, that you're the only person struggling, whether that's
Mm,
erectile difficulties, vaginismus, or shame, or if you've had risky sexual behavior and a lot of shame around that, just to know you're not alone, and
mm,
that there is support, and that really just, like, I'm very passionate about creating more awareness around this area of health, because I do think it's health and it's part of
yeah.
your mental health, your general health, your, like, sexual health is health,
Yeah.
and just giving yourself permission to have those conversations with
Mm,
clinicians, or people in your life, whether that's your GP, psychiatrist, nurse,
yeah.
or if you're in a physical health team, say for cardiovascular or oncology,
Mm,
if you've got concerns, maybe having a conversation. And
yeah. Great. Yeah, no, thank you. And thank you so much for your time and your expertise this afternoon. It's been really, really interesting. And I think you're doing a great job actually in kind of having those conversations. So I'm really glad that we have been able to have it today, you know.
yeah,
And who knows, we may have other different types of kind of discussions around this, because as you say, sexual health is health, and mental health is also key to health. So
yeah,
it's
yeah.
these are conversations we should certainly be continuing. So yeah, so thank you so much.
Thank you, Susan. Thanks everybody as well, and thanks for the questions.
Yeah, absolutely.
Yeah,
Thanks for joining. Thanks for sticking with us till to the end of this afternoon, and then moving till to next month. Excuse me. Sorry. So we're going to be talking about loneliness next month. So that's the 10th of September, understanding mental health impact of loneliness. So hopefully many of you can join us there. So just to say thank you all very much again, and hopefully see you soon. Thank you.